about last year, William Ruto was sworn in as president of the Republic. He'll be marking 1 year in office this week. So before he got elected into office, he had signed several charter with various sectors. You know, there's a county charter, the youth charter, the business charter, the charter. I don't know. Was there a health charter?
Yes, it was.
Not actually a charter, but we presented a memorandum and we had some agreements.
So you sat down and discussed the memorandum
for a whole day
with the candidates.
Yes.
And you did not sign anything. Everybody else was signing.
Yeah, we gave our memorandum.
This forms the basis of our conversation this morning. Peterson Wachira is the national chair of the Kenya Union of Clinical Officers. He is our guest today. We are looking at, as the Kenya Kwanza administration marks 1 year in office, how's the health sector doing? Karibu sana, Peterson.
Thanks a lot.
Good to have you here.
As I always say, it's an honor and privilege to sit here where great men and women sit and discuss matters of national interest.
Hey, umesikia hiyo city.
Sisi umeandika hiyo?
Great men and women sit.
Yes.
I have
Great discussions.
Of
great meaning.
Very good. We also serve tea here, Peterson. Yeah. Chai, ile chai ya maziwa.
Ile ya maziwa.
Ile ya maziwa.
Ile mzito.
Na maziwa bora ni Dairy Best.
Yeah, Western.
Dairy Best. Dairy Best milk. From Brookside. It's long life. You know that packet?
Yeah.
Right? That means you can buy it and take it wherever. All your union members, whatever part of the country they're working, they can actually have Dairy Best. Because it's long life, they can just store it. They don't need to think of free refrigeration. Just store it in a cool, dry place.
In the facility and we don't have time to go for lunch, we can also grab one.
Grab the Dairy Best.
Diet.
Yo.
Yes.
Daktari amesema. Bas.
Maziwa ni nguvu.
Bas. City. Give him the day's proverb.
Our proverbs for the whole of this week are from the country of Sierra Leone. Quarrels end, but words once spoken never die.
Quarrels end.
Yes.
But words once spoken never die. But Wachira, what do you make of this proverb? What's your interpretation?
I think first of all, at the face value, it's very true that when somebody is angry, they are bound to make some statements that may hurt the other person, that may deeply cut into the ego and emotions of the other. And as they usually say, that the people will forget probably what you said, but not how they felt.
Right.
How it makes them feel. They will never forget that. So I think what it means is that you should be very cautious when angry, and especially on what you say, because how what you say makes the other party feel, even after that quarrel is over, they will never forget.
That's true.
Yeah.
Easily said than done, though, isn't it?
Yeah, true.
Because at that point, when you're in that argument, you want to inflict as much, you want to score.
You want to hurt, you want to injure.
You want to score points. So what you're just saying is, at that moment, just walk away. Just forget about lose. Accept, agree to lose. Okay, I'm losing this one. I'm losing. Let me just walk away because wewe nikisema hautakumbuka. So tell us about this meeting that you held with the candidate William Ruto as the health sector workers in the country. Who was in the meeting? How was the meeting conducted? Who invited the other?
Yeah, so before the election, I think that was around 2 or 3 months before. I can't remember the exact date. We were invited by his team to Catholic University, where we spent the better part of the day, I think from around 9 to around 3, just discussing matters health. And
who's we in this case?
We is the unions and the associations in the health sector. And we had a great conversation surrounding many issues that affect healthcare. And of course, on what we think would be the solution that would give us the health care that we actually need as a country.
Yeah.
I think at the end of it, we were able to present a memorandum. And it was not just a memorandum that probably the union sat back and thought of. These were resolutions from a convention that had been convened by the unions and that brought together all the players, basically all the players in the health sector. From the Ministry of Health, it was actually opened by the Cabinet Secretary and the chair of the Health Committee in the Council of Governors. So the Ministry and the Council of Governors were participating. We actually co-planned. And it was actually closed by the CS Labour, who read out the resolutions. We had all the association, including the Association of Patients. We had all the unions, we had the partners. AMREF actually was a co-convener of the same. And at the end of it, we came out with resolutions on what we thought would be the best path towards universal health care. And this is what we presented to the president, and actually part of the plan on health was actually informed by these resolutions. Yes.
So, what was the agreement at the end of this meeting?
So
that the
there
candidate
were
and his team are going to look at this, and once in office, they will implement some or all.
Shouldn't be some. When you commit, you commit to what you have to implement 100%.
Okay.
So our discussion surrounded the fact that our health system was not working. It is still not working. And that we needed a remedy. And one of the reasons why it was not working, one was overemphasis on curative and neglect of preventive. And our understanding has been that when we say we want to guarantee Kenyans of their health, you cannot do that by basing your health system on curative. Simply, in simpler words, saying that we sit in the hospitals, then the citizens are on their own. Once you fall sick, then you find us in the hospital. That is not guaranteeing health. You can just guarantee them that I'll try and alleviate and restore once you're sick. So we discussed on a paradigm shift from the curative to the preventive, and I think that is something that is documented in the plan, and I can see that there are steps to move into that direction, into the primary health care, which is a good one. We also agreed that, and this was coming from the commitments that have been made by the government, that one of the reasons we even neglected the preventive and went for curative is because health workers became firefighters. In the past, we used to have health workers, especially clinic officers and nurses and public health officers. We could go to the community. We could go to the chief barazas. We could go to the schools. We could do family diagnosis, and we could prevent diseases before they occur. But at some point, because there was no commensurate employment in relation to the population growth, at some point we became too few. And so we became firefighters. You can only wait for those who are sick because you are not enough to also prevent.
Yeah.
And that is how we shifted from preventive to curative. It was not like a policy decision. It was just because of the shortage of healthcare workers. And so we decided, and we agreed, that this government, within the 100 days, they were going to employ 20,000 healthcare workers, actually broken down in the plan to be doctors, clinic officers, nurses, laboratory technologists, nutritionists, among others. And this was borrowing from a commitment of this country as signed by CS Macharia when he was the CS for Health in Brazil, when he attended a WHO conference on health human resource, that we were supposed to be employing 12,000 healthcare workers each year from 2013. By 2018, it was projected we should have employed 60,000. And by then, we had actually done less than 20,000. So the other thing we agreed was that there was need to have an emergency fund and for emergency diseases and chronic and critical illnesses. We're also seeing steps in that direction, and that's a good thing. We also agreed that we needed to have, in line of the promise of digital superhighway, that we can digitalize our information in the health sector. I have also seen a bill which we are interacting with, and I think that's a step in the right direction. We also agreed that there was need to have reforms in NHIF, and especially to ensure that it works for Kenyans. I'm also seeing some steps in that direction. We must give it to them. But we also agreed that the reason we have had over 100 strikes in the last 1 decade of devolution was because our modalities of management of health human resource, of health workers, was ineffective, and that we needed an effective way to manage health human resource. And so, and it is committed actually in the plan that he was supposed to midwife a health service commission that does not undermine devolution. And we went further. Actually, because this came from the resolutions that we had made in that meeting of March 2022 at Safari Park, we had laid down the process of achieving that. And what we had resolved as Kenyans, because that was a meeting of Kenyans on health, was that we needed a task force so that those people who are concerned with health can actually sit together and they can deliberate. The unions can say that we want a health service commission. The governors can say, no, that's not the solution. And then we ask, what is the solution? And we come to an agreement on what is the best way forward. But that task force, which we had agreed that was to be formed, has not been formed so far. Okay. We actually wrote to the president, and he wrote back through the chief of staff, and the responsibility was given to the CS Health. That is yet to happen. I think more than 6 months now down the line. So we don't know if actually we are still on that commitment to have the task force.
Okay.
Yes.
Peterson, one of the things that is coming out clearly is that there seems to be confusion on this side in terms of confusion in the mind in terms of what is going to happen based on what the memorandum said. The question is that was the memorandum collected and said we will act on this as an incoming administration? So that's something to think about. But then there's also the assumption that because UHC as an entirety, as a program, is being launched next month, that there could be fallacious assumption that matters health then are being attended to. You see what I'm saying? So because UHC being launched officially next month, and them knowing that, okay, once you're going to have universal health coverage, that then certain issues will be attended to almost automatically. So there could be assumption that, well, we're handling this, and they're saying, yes, we said 100 days, but look, it took some time to get some ducks in a row. Do you feel that with the coming in of UHC, with the understanding that they have matters health somewhere in the front and center of their thinking, that these issues that you speak of will be handled?
Let me say that the promise on UHC by this government is actually an ambitious one, and it's a good thing, because what this regime promised is that we are going to move from universal health coverage to universal health care.
Yeah.
Those are two different things.
Indeed.
When you say universal health coverage, it means you get that service closer to you at an affordable cost.
Yep.
But now when you're moving to care, you also want now to audit that service in terms of quality. What type of quality, what quality of service are you getting? So when you're moving from just coverage to care, you're looking at quality. When you're looking at quality, you must then look at the 6 components that make an effective health system. Among them, and what has made actually, you had the CS saying that UHC has failed, I think 3 times. They are trying the 4th time. What has made UHC to fail is simply the avoidance on the conversation of health human resources. Because health is not like the other sectors where you can get machines, robots and whatever, and then you'll be able to probably produce. Health is human intensive. You have to have medics because it is the medics who offer that service. But we have seen continuous avoidance on the conversation of the health human resource. And now what you can see the government doing, though there was also a promise on the community health promoters, and which we actually don't have a problem with, except a few things that we want aligned. You note that up to this time, you cannot hear the government talking about employment of the mainstream health workers. And as long as we avoid this conversation, as long as we don't have a framework that ensures that we have progressively and a very deliberate plan to ensure that we employ enough healthcare workers to meet the WHO staffing norms and standards, that is 23 healthcare workers per 10,000 Kenyans in the community. There is no way, there is no magic, and there is no way we are going to achieve universal health care.
I'm sure, Peterson, you hear what what has been said, whether it's been said loudly or whether it's been said, in the shadows. That in terms of I don't think that there's a shortage of health workers in the country. There are trained health workers, whether you're looking at doctors, nurses, clinical officers, lab techs. It doesn't matter what cadre you're looking at. There are enough. The problem here is that the power to hire or the power to employ, which most times is vested in the finances that are available, then becomes the issue. Do you think that there is an issue in terms of finances, county to county, coming from the National Treasury to hire the 20,000 that are needed? I think it's more than 20,000 that are needed in the country today. If we're looking at 1,000 Kenyans to one doctor, which is what the latest numbers are looking at, it's ridiculous. However, we're being told that there's just not enough to go round. There's not enough to employ. And when I say enough, I mean shillings. What do we say about that?
First of all, there are not enough trained healthcare workers in this country.
They're not?
Yes, all of them combined. Those employed in public, those employed in private, those who are not employed. If you combine them, we are not actually enough.
Really?
We really need to train more to get to that
number.
So please explain. When you say they're not enough, what do you mean? At what point will we know they're enough?
Let me give an example of clinical officers. The ideal number, if you have to do both the preventive and curative, if you are going for that approach where you have the primary health care and the other levels of care, you would need one clinical officer for 500 Kenyans.
One clinical officer for 500 Kenyans.
Yes.
So you're inviting me to do the maths.
Yes.
Since we are 50 million.
50
plus.
million.
Yes.
So I just do minus plus. Okay.
That would be, if we even went with a double, I think to one to around 1,000, and you are to divide 50 million by 1,000, what would that give you?
Okay, so if you did 50 million divided by 500, you get 10,000. So
Yes.
today, Kenya needs, if one clinical officer were to meet the needs of 500 Kenyans, you would need 10,000 clinical officers in Kenya today. Do we have 10,000 clinical officers in Kenya?
Not 10 more.
It's not 10,000.
It's more.
50 million
It's
divided
500.
by...
It's 500.
It's
50 million.
500,000.
Oh, it's 50 million. Sorry,
Yes.
I did 5 million.
Yes.
So it's 50 million divided, so it's times, okay.
Yeah.
That
So you
is
need
50,000.
Yes, you need 50,000. So do we have, so two things here. Obviously, we don't have 50,000 clinical officers in Kenya today.
The ones who are
Do you
registered for now are around 27,000.
Okay.
All
do
of
you-
them.
Do you have the capacity to train another 23,000 clinical officers? And we're speaking just as clinical officers. We're not talking about nurses. We're not talking about lab techs. We're not talking about doctors. Do we have the capacity to
train.
bring in another,
Yes.
train another 23,000
We do.
and bring them into active employment? That goes back to my original question, that most times you'll be told, well, we don't have enough wiggle room in terms of shillings
Yes.
to make this happen. From your point of view, is it possible?
Yeah, I think training, we can be able to increase the capacity and train more. But there is no incentive, since you train them, they are not absorbed. But the issue of finances, I think the government has enough money for its priorities. Why is it that we have a policy by the government that we're able to employ police every year, the army, the teachers, but not the healthcare workers.
Teachers will argue that they've not been able to hire every year.
In fact, teachers argue that what they do is they replaced retired teachers. They don't actually employ new teachers. So the number more or less remains constant.
In health sector, they don't even replace them. But let me say that health is not cheap. And what is the cost? What is the cost of not having these healthcare workers vis-a-vis an investment that you would make in employing enough healthcare workers? I think it has been shown that for every shilling that you are going to invest, especially in the preventive healthcare, you save 9 shillings out of 10. Okay. Every 1 shilling, you save 10 shillings. But look at it in this context, in terms of economics. When we are having a shortage, let's talk about just a shortage of clinical officers so that I can use it as an example. And to even bring the point home, I want to use a very close example. During the time of COVID, my dad got COVID. He appeared to the first facility. My dad is 70-something years. He appeared to a certain facility. They never diagnosed.
Public facility?
A public facility.
They never diagnosed.
What level?
COVID.
What level?
Okay.
That's a level, I think a level 2.
Okay.
Then went to a private facility, around a level 3. Went to a facility where he was seen by, the 2 are clinic officers. The third one was seen by a doctor. The 4th one was the Nakuru Provincial General Hospital. The first time, nobody picked. There is an old elderly man. He's obviously having difficulty in breathing. It's during the COVID time.
He had all the symptoms.
He had all the symptoms.
Yeah.
So myself, because we would talk on the phone and I would tell there is something wrong, and of course I was talking to my mom, I sent him back and with instructions. They must do 1, 2, 3. And then he's diagnosed. Then through the process somewhere, they still let him to go back home. And by then, the oxygen concentration was actually 70-something.
Wow.
Wow.
So I had to actually intervene. I went there, and by the time I was going there, he had to be admitted to the HDU. So, of course, I was very angry. But then, very objectively, I undertook upon myself to go and audit. Why did these people miss something that would be expected to be obvious?
Yeah.
So, on going to Nakuru PGH, I found that one clinic officer sitting in that outpatient, on average, was seeing around 150 patients
Per day.
per day.
My goodness.
If you go by the timeline provided, if you are to see a patient for at least 15 minutes so that you can make a good diagnosis, the best you can do in 8 hours is about between 38 to 40 patients.
He's doing 3 times, 4 times that.
Yes.
He's doing 4
So
times.
what that means is by the time I'm doing my 100 patient, actually I'm fatigued.
You're tired.
The moment you are getting into that door, I'm wishing you can leave because I'm really fatigued. And so I'll be mentally crowded. If you are to Google the symptoms of fatigue, you'll see you lack alertness, concentration, you're mentally clouded. You cannot make a good judgment.
But is that even possible? Because what are we saying? If you're seeing 100 patients a day and you're giving each patient
3
an average
minutes.
of 3 minutes,
It will come down to that. It means
you
that
can
you're
only
not
see them for
giving.
3 minutes. You cannot see them for 15 minutes.
In that
because
sector,
if you
we
say
call it
15
clearing and
minutes,
forwarding.
Yeah.
if you say 15 minutes, that's 25
That's
hours.
why someone comes, unasikiaje?
Yeah.
Ilianza
Yes.
lini? Ilianza lini? And you
That's what happens. Sometimes you are given a prescription before you sit. And I think that is where we have driven the medics, because then you don't see them. The MCA is there. We have seen our clinic officers being slapped by MCAs that they didn't see their
You're not
patients.
seeing a patient.
But what I was coming to is that now imagine the money we paid to admit my dad to the HDU.
Yeah.
We had to sacrifice a lot,
Yeah.
and it was a lot of money. So if you look at the cost of that complication that comes from that misdiagnosis, if you look at the money you utilize because you had a disease that you would have prevented in the first place, and especially in Kenya that most of the people cannot actually use NHIF, they have to do out of pocket, then whatever we are losing cannot be compared with whatever we need to invest to just ensure that we have enough healthcare workers so that they can be able to take care of us.
That's a good one. Let's take a break. Let's take a break and then continue. 26 minutes to 8. Kenya's biggest conversation, the Situation Room, hosting Peterson Wachira. He's the national chairman of the Kenya Union of Clinical Officers. We are looking back into the 1 year of Kenya Kwanza administration this week. How is the health sector doing? He's telling us the conversations that they had with candidate William Ruto, the conversations that they've had with the government of Kenya Kwanza this far. And are they happy? Are they not? We'll be back shortly. Good morning. All right, the conversation continues 22 minutes to 8 with Peterson Wachira, the national chairperson of the Kenya Union of Clinical Officers. We are talking about human resource for health, human resource in the country. Peterson, are you aware of the Kenya Health Human Resource Advisory Council?
I am.
That was established by the president.
Yes.
When was this established and what's the function of this? What are the terms of reference?
Actually, KHRAC, the Kenya Health Human Resources Advisory Council, is a product of the Health Act of 2017. Mm-hmm. The previous regime was unable to inaugurate it and to make it work because there was a problem with the governors. The governors believed that this was a health service commission, in other words. And of course, they fought it.
Yeah.
But what I think this government has done, and it's a good thing, it has managed to mediate. And now I think the government, the governors are actually on board. And now we have a full board. So it's operational and complete with a CEO. So what it does is that it is supposed to give policies in terms of health workers' welfare and schemes of service, in terms of posting and payment of interns in the health sector, rotation of specialists, among other things affecting the health human resource. So they're supposed to set the policies, including, and the most crucial, the inter-county transfers and the vertical ones from the national to the county governments, because we don't have that framework. So it is a very important council. The only problem is that it is advisory.
So it's operational now?
Yeah, it has been
established
operational
by law.
Yes.
Hasn't been operational before. Now it's operational.
It is.
After conversation between the president and the council of governors and agreeing, look guys, this is what we need and let's have it.
Yes.
Have the interns who were employed by the national government during COVID, have they been absorbed?
Yeah, now, you see, we have
let's go step by step.
two different
levels of interns.
Levels of interns.
Okay.
So for the ones you are asking about, it was a case of use and dump. They were recruited during COVID. They worked for the government. Then when COVID was over,
you're done.
They were dumped.
Yep.
And I think it's a very bad practice that we are having in this country, and especially in the health sector, where you bring in some sort of contracts. You can see even what happened with the UHC, which was a good thing. That President Uhuru was very deliberate, wanted to capacity build the counties, increase the numbers. But then they give contracts that are a bit exploitative. And then you want, once that problem is over, though still you need health workers, you want to dump them. And we launched a petition with the Senate regarding that issue. We are expecting a report soon, so that these people can actually be absorbed, and so that we can also appreciate them. You can imagine, some of these guys actually died from COVID. But then those who remained, instead of a country honoring them, these are people who even deserve presidential commendation.
So their contracts just ended, and that was it. Has there been a conversation at all about the fate of these workers? In any way, in terms of even the national government committing that we are going to renew their contracts and support the counties for a while as we build their capacity for them to be able to be absorbed by counties?
For UHC staff, yes, there is that conversation, although we are having confusion because the summit met in Naivasha. They said we are going to extend for 3 years.
Yep.
as we try and get a mechanism of absorbing them, I also know that there is a committee in place at the national level looking at that. Then the Public Service Commission came and said, no, it should be 1 year and then you absorb. And what is reflecting in their pay slips, it is that of the Public Service Commission.
Yeah.
But the bottom line is that as long as then we will be able to absorb them and absorb them with the right pay, appreciating them, and also ensure that we don't give them the entry job group. This is a person who will have worked probably for 5-6 years. They should be going to probably the third job group, because anybody who was recruited when they were recruited would be in a third job group. Now, the other category, they were called CHAPS, COVID-19 Health Emergency Response Program. Those ones were let off, forgot, and they have really been petitioning. They came to us. We launched a petition with the Senate. We have been there with the CS Health. We have been there with the Chair Health Committee and Chair Labor in the Council of Governors. And the indication is that for their consideration, but we are hoping that happens, because it's a very unfortunate. What's
the position of the government on this?
Occurrence. So the government's position was that their contract ended.
And that was it?
Yes, yet these are people who gained very good experience, and people that you'd expect that are being absorbed so that they can continue serving Kenyans. So on one side, we have a dire shortage, not my own words, but by the commitment from the CS of Health to WHO in 2013. On the other side, even the important human resource that we are having, we are not keeping. We are not establishing mechanisms. We ensure that we retain, and especially the expertise. And I think that takes me to another conversation about the contractual, the mode of engagement that we are using in the health sector, the contracts. You see, if we keep on giving these short-term contracts, because every governor wants to come in, give contracts, and then they end by the time they are leaving. The other one comes in, does not renew, brings other new people. And the contracts which are very exploitative, you find somebody is being paid a third of what somebody on permanent is being paid, which is illegal. But that is not even the issue. The issue is, if we take this as a policy in the health sector, and then over time, those who are on PNP, most of them have been able to specialize, because you can be taken back to school. You have enough money, you can even take yourself back to school. Now, when you have contracts and that are cheap and exploitative, it means, one, you cannot take them back to school, because that specialization requires the time you have given them contract. Number two, they don't have even enough money to take care of their families. They cannot take themselves to specialization. So in 2 or 3 decades, when we on permanent will be phased out through retirement, I can assure you, for a simple specialist, that gynecologist that you find next door, you might actually have to go to Uganda to get one.
So this then now makes the claim for, and the case for what many amongst the fraternity have been advocating for, which is the Health Service Commission.
True.
So the Health Service Commission essentially will handle all these hiring matters. It doesn't matter whether you're working at the county level. It doesn't matter if there's a new governor or if this one is coming to the end of the administration. But what you do is then make sure that folks are employed across board. How would that help when we're looking at the devolved units?
True. And I think what we had committed, because we had a very candid conversation with the president, and the concern was, there would be a conflict with the counties because health is devolved. But actually, that is not correct. Health is not entirely devolved. Health is a shared function. Policy with the national, training with the national, capacity building with the national. The implementation is what happens at the counties. And that is why I always say that the buck stops with the president, because it has been provided in law that leadership comes from the national government, and the head of that is the president. So coming to the Health Service Commission, we had actually crafted, and we even presented during the BBI, on what we believe can be a health service commission that sits in well with the devolution. And this is what we are proposing, that we have a health service commission that will be recruiting for the county in this way. The county sends their requirements and their needs to the commission. The commission can only employ as per the requisition of the county. Then the county will have delegated powers, especially on disciplinary redeployment within the county, but they cannot terminate you. If you need to be terminated probably or to move to another county, you go back to the Health Service Commission. And the benefit of this would be, right now, according to the PFM Act, your recurrent expenditure cannot go beyond 35%.
Yep.
We have been lumped in the recurrent expenditure.
At county level.
Yes. And most of them, they are not able to employ because they have surpassed the ceiling.
You people are expensive.
Yes, but no, we are not expensive.
Okay, go on.
But if we were to take it to another entity like the Health Service Commission, the same way we have TSC, number one, there wouldn't be those caps.
Yep.
If money is for recruitment given to the Health Service Commission, it's for recruitment. So a budget can be set aside from the Treasury for recruitment across the board. And that would not be in conflict with the county government. It would actually help them, because when you remove the health human resource, which takes a lot of their money, then they will be able to stock the drugs that are never there in the hospitals, to equip their labs, to ensure their reagents so that we don't send patients out. And it would probably make health better for Kenyans.
Why has it not worked that way?
It has not worked because of politics. I think...
Do you still think it's because governors don't see the sense of this point?
I may not be able to tell about the current governors because probably they are only 1 year, and this is a conversation that we have not had. Some of them, by the way, they have indicated that this is something that can be considered. But during the last regime, the moment you said Health Service Commission, because I think at some point we met during the BBI, for the governors, it's the end of conversation, and they interpreted that to mean returning health back to the national government. Of which it's not true. We don't want it returned to the national government. We wouldn't even be happy to be at the national government. We want an independent commission that technically manages the health human resource, so that we rid health of this politics, where every governor wants to come in, remove those who are there, bring in my people, then next time you get a new governor and does the same. And do you know, in some counties, health workers are actually employed and called cashiers. They actually call them professional cashier workers, and paid a third of what others are being paid. And these are the people who are supposed to now implement universal health care.
It is quite sad. We also know that health is a big ticket item at the county level. So county executives who've done well in the health sector often use it to, wave the champion's flag that, look, our health is in a great state. And we've been able to do that. So you can imagine a situation now when you want to remove something that gives you celebrity points and take it somewhere else, right? If it does well, it does very well. If it does badly, it does really very badly. And that's the truth with some of these examples that you're talking about people being paid a third of what they should actually be paid. Aside from the Health Service Commission, which we've seen the merits, of it clear when it comes to the protection of health workers, when it comes to that making sure that human resource for health workers is vested in some kind of order, what else would be necessary to get health as a sector off its obvious knees at this moment?
Very good. I think other than the Health Service Commission, and we continue saying this, we must be very deliberate about our health. And in being deliberate, we must also be able to put in plans. And one thing I like about our president, His Excellency Ruto, is that he's very deliberate about what he wants. And that is why we would like to request him that let's have the 20 employed and have a framework to
20,000
annual recruitment. Yes, 20,000 as promised in the plan. And I know that the conversation is about the health promoters. And we have seen the 4 bills that have been brought, and that they want to repeal NHIF and replace with the SHI and the other 4 bills. When it comes to health promoters, it is actually a good thing. And we will recruit 100,000. That's a good thing. But then we must be very cautious, because I've seen in that bill that we want the health promoters to offer first aid and to treat minor illnesses and injuries. But in the requirement for their, not employment, for their engagement, because they are not workers, you just need to be literate.
So are they going to be trained?
You don't need a health background.
Are they going to be trained to perform these functions then?
There is a training, I think a short one, which cannot,
It's not sufficient for the
By-
job that they're being given.
by
to do.
saying minor illnesses and injuries.
Well, they're not being specific as to which injuries.
Yes, that would mean they even give antibiotics.
Can you diagnose malaria?
That's what actually it means, and we have had those suggestions that
Mtu ako na malaria unampatia.
I think in even one of the meetings the president said hii magonjwa kidogo wanaweza kutibu pale nyumbani.
No, but actually, Peterson,
Yeah.
when you talk of malaria, diarrhea, and pneumonia,
Yes.
you actually can't treat it. But a study was done and has been done, and the findings out in the public domain
Yes.
about how it is these very community health promoters could actually diagnose syndromically, as he will tell you. But the understanding was not so that you treat it, so that you allay the problem before you pass it onward to a health worker. Meaning, you are in a village setting and somebody has fallen sick.
Yes.
And there's nothing you can do. So,
And administer cold compress.
precisely. There's something you can do. You're not going to suddenly say, okay, now, please prepare yourself. We're going to open up your chest. Nothing of that sort. But you can actually provide a care that will enable that person to go to the next place where they will actually receive treatment.
So that's what they meant by the
No.
Kidogo.
Peterson has said you have to specify.
That is very vague.
It has to be very clear.
No,
Very dangerous.
And this person is just somebody being given a stipend of 2,500.
This is
and
the
a
thing.
Tibu in the
Actually,
community they'll be
5,000.
called a doctor.
It's dangerous.
But it must be commensurate to then what they're actually able to do. Is what we're
Yes.
saying. That you cannot have the blanket statement whereby you say, okay, yes, we're going to give you a stipend of 2,500, 3,000 shillings, and then say anybody who rocks up to your
Strike
door.
Kuskia typhoid.
Imagine.
Now, you
That's what we're
see,
saying, yeah.
these people, they are community health promoters.
Yeah.
Health promotion is defined.
Yeah.
And health promotion is about educating people about the diseases in their locality.
Wash your hands, dispose
Yes.
of waste kind of thing.
How do you prevent it? Once you get it, how do you know you have it? And what do you do after? I think in this country, there are guidelines as to how we should have the facilities. And that is, per every 5 kilometers, we should have a dispensary with at least a nurse and a clinic officer. So in a radius of 5 kilometers, you should be able to call them in case there is an emergency so that they can administer competent care.
Yeah.
But where we want to give them antibiotics, I had some suggestions that we give them amoxicillin to dispense in the village.
That's dangerous.
And on the other side, WHO is talking about antimicrobial resistance.
resistance, exactly.
That cannot happen. But that is not even the issue. If we get these health promoters, we bring them on, they are going to improve the health-seeking behavior. Kenyans are going to flock into hospitals.
Are you ready?
And then when they flock into hospitals, they find there are no medics. So the frustration that in the first place made them not to come to the facilities because of the long waiting times, even when you are saying you don't have drugs, if you are not going to sort that, it will become a zero-sum game. You promote it, they come to facilities, they get frustrated, then they give up and go back, and we are back to ground zero. So there must be a commensurate plan to also employ the mainstream healthcare workers, especially at the primary healthcare level, to ensure that there is a commensurate staffing level, so that when these people are now brought to the facilities, they can get that care and they will appreciate that actually now health is working. They will come back into the system. We are not seeing that. We have not heard that from the government. There is avoidance on this conversation of health human resource. But I want to keep reminding them, that we can talk, we can employ the community health promoters, we can try all the other things. But if we do not get it right with the mainstream healthcare workers who actually deliver this service, it will be a zero-sum game. We will not achieve it.
So we can we can repeal NHIF Act and create these other bodies.
Yes.
We can have all these other bills, but for you, the bottom line is start with the 20,000 workers.
Because that service that you're promising them and you want them to gain when you're talking about creating a fund for emergency and critical care, who is suffering that service? It's a health worker. When you're talking about primary health care, you are talking about dispensary, health center, and the primary hospital, which is the sub-county hospital. Who is offering that service? It's a human resource. It's a health worker. When you are talking about the other one is about the digital superhighway. The people you still need are people who are trained on information, but who are still health workers. So the bottom line is we will have the bills. By the way, the bills are very good. Creating an emergency and critical care fund, that's a tick. Primary health care and that paradigm shift to prevention, that's a good thing because we are going to bring the cost of running health down.
Digital
when we talk
medical.
about SHI,
Tick.
very good. When you talk about digital, tick. But if you do not have the human resource, there will be very good bills. We will do what we do as Kenyans. We have very good paperwork, very nice.
Collecting dust.
In fact, we export. Like whatever Rwanda is using to implement the universal health care
is our work.
Is our blueprint.
We need IP.
But they are ahead of us because we never implement.
We need to register these things with IP. Anyway, Peterson, thank you very much for joining us
Thanks
today.
a lot.
Always a pleasure having you and having these conversations with you.
Always an honor.
Peterson Wachira is the national chairman of the Kenya Union of Clinical Officers. He's been our guest this morning talking about health and the health sector. How's it faring? Is it ill? Is it healthy? As President Ruto marks 1 year in office, that's been the conversation. Keep it here for more.